got stuck because of the volcanic ash, and ended up, it was kind of feeling like you were a character in one of those Cold War novels or movies trying to get back home where it was safe, because everyone was scrambling, utilizing any types of transportation that you could get, car, bus, train, etc. And ended up having to go by train from Vienna to Villach, Austria, which is at the corner of Italy, Switzerland, Austria, and one other country there, whatever that country in that corner is. And then a bus from Villach to Venice, another train from Venice to Rome. Was able to get to be in Rome for a few hours that it was open that day, to get a plane from Rome to Madrid, and then finally was able to fly from Madrid to Chicago via Dallas, and then finally here last night. So it was quite an adventure. Anyway, back in 1988, Franny Moore wrote this article that really recognized that transplantation was affecting ethical principles in regarding to health care, and described them under these three categories: scientific data, field strength, and the climate of the institution. And really, from that time and before, he really recognized them and wrote about them. Amazingly enough, he never published it in anything better than Transplant Proceedings, which is just incredible, because it's a very important article and principles within transplantation, looking at how transplant really does change and make a more significant impact in each of those areas. And since then, transplant has been trying to deal with these issues in a number of different ways, not only in the United States, which we continually try to address with regulations and conferences, etc., but as well throughout the world. So liver disease is a worldwide problem. This is once again one of these issues of the colors on this projector. But anyway, hepatitis C worldwide, and in the U.S. we think that we have a bad problem with hepatitis C, but we're really in around 2% in terms of the prevalence in the United States, and there are places that are far worse. Hepatitis B, if you're at less than 2%, you don't even get a color. You get the white. And so the rest of the world, including many of the very populous areas of China, India, sub-Saharan Africa, have a huge problem with hepatitis B. So the problem with liver disease is truly a worldwide problem, and we have to figure out how to address it. One of the problems in terms of liver transplantation is, unfortunately, many of the areas that have high incidences of liver disease, hepatitis C and B, are not the areas that have high donor rates. So donor rates in North America, in Argentina, and in Western Europe are much higher than the rest of the world, but they're also the areas that in reality have the lower incidence of liver disease. So there's certainly a maldistribution between donors and the need for the recipients. So the first ethical challenge is to determine whether access to transplantation is a global issue or if it's a series of national issues. So UNOS has weighed in, as usual, on this issue in a rather contradictory fashion. They have a 5% rule in which if you're a center, you cannot transplant any more than 5% of your deceased donors that are from going into foreign nationals. That's what this says. The contradictory aspect of that is that they also have a policy that you have to be non-discriminatory in organ allocation. in which selection from the waiting list of non-resident alien candidates for transplantation shall be based on the same allocation policies mandated by the Board of Directors for selection of domestic candidates. Such selection shall not be influenced by favoritism or discrimination based on political influence, national origin, race, sex, religion, or financial status. So if you have a patient that's on your list and he happens to come at the top of the list and get an organ offered, if you happen to have already transplanted 5% of your patients, 5% of your patients into foreign nationals already that year, or 12 calendar months, or however they want to describe that, then you're going to be breaking the 5% law if you abide by this law. So it is very contradictory in terms of how UNOS tells us to try to deal with this.
Who monitors the 5%?
UNOS. And if you go over, then they send you a letter and they come investigate and all this other stuff. There's some justification of this 5% rule when it was first put into place very soon after the establishment of UNOS. There was the ethical justification was that that's about the percent they thought that of deceased donors would be foreign nationals, and so they said that would be a good way to cap it. Really, the political justification was what was really driving it, was that there was a concern that the global demand for organs, specifically livers, would overwhelm the supply and diminish access to transplantation by U.S. citizens. The current justification is that if we allow easy access to transplantation to areas of the world that have lots of donors, then other countries, it will diminish their drive to develop organ donor systems. So those are the three kind of justifications for the 5% rule over time. So globally, there's also issues. Europe, where I just was, has a 5% rule. Britain, however, has a 0% rule, except for, quote, inferior organs. And so every organ must be offered to a British candidate before it is offered for any foreign national. Some countries, especially in the past, have encouraged transplant tourism. Pakistan recently passed a law banning transplant tourism. Colombia in South America still encourages transplant tourism, as does India. And prior to some of the work that we've done with the China regulations was encouraging transplant tourism as well. When you start thinking about transplantation and ethics and why there's so much controversy and discussion regarding transplantation, who should get it, when they should get it, how they should get it, where they should get it, etc., you really come to start questioning, well, there's really not that much discussion about the diseases that lead to transplantation. We have end-stage renal disease and we have dialysis. There's always some discussion about who is a real candidate for dialysis, whether somebody is too old to start dialysis or not, things like that, but not a whole lot of controversy. Hepatitis B, certainly there's universal acceptance that there should be vaccination. Hepatocellular carcinoma is a problem, but there's not a lot of discussion about who should get treatment for it, who should not get treatment for it, etc. Even care for patients after transplantation. Rejection, recurrent diseases such as diabetes, FSGS for kidney transplant recipients, Hep C, hepatocellular carcinoma, once again are issues, but don't really get to the level of passion that issues regarding access to transplantation gets in the United States as well as the world. And so the answer to this comes about in that organs are a scarce resource. We have money that is relatively scarce and may become more scarce in the future with national health insurance plans, etc. But organs really transcend the financial aspect, although there's certainly a price for them. But we also really, from an ethical point of view, must protect and have the consent of a third party in every transplant that we do. Whether that's a living donor or whether it's a deceased donor, we have to protect their rights and their families' rights. and get that consent. And that's really when you drill down to the ethical issues regarding transplantation and how transplantation differs in the ethical principles that we have to deal with versus the care for other patients. It's really the fact that there's always a third party that makes the difference. So we must protect the donors, that third party's donors' rights and concerns before and after donation. At least that's what we feel in transplantation, whether that's a living donor or a deceased donor. We must protect their gift. And patient selection committee, certainly part of the discussion is frequently to make sure that the potential recipient can take care of the organ, whether that's being able to afford medications or has the psychosocial support, family support, etc., in order to make the correct healthcare decisions. It is clearly a part of the decision-making process. And then in regards to program quality, there are regulations to try to ensure that you're not just going to any transplant center, you're going to a transplant center that has the infrastructure that would be able to protect the gift of the donor, i.e. provided a reasonable outcome in terms of graft survival. The care between a physician and a patient is at its broadest national level and is more likely a local issue. However, it is generally agreed, at least in transplantation, that the rights and ethical treatments of donors, of that third party, are universal. And so here's once again the distinction between the recipient and the donor, the discussions between the patient who has a disease and the physician, and what the therapies may or may not be are a local or perhaps state or national issue in the states. In other countries, they certainly have some national oversight of those, but the rights and the ethical treatment of the donors is a universal concept. So in regards to the global transplant ethic, it's really moved from the U.S. and Western Europe trying to lead the way to really trying to grasp that into a global scenario. And whereas medical tourism is generally accepted, at least not to think of it as an unethical practice, transplant tourism is worldwide felt to not be okay. The ethical foundations of these have been discussed in a number of different conferences, of which the UFC has played important roles in each of these. The Vancouver and the Istanbul, really trying to establish these ethical principles and then spread them out globally. So now we will go ahead and take a trip to China, even though the pictures aren't showing up very well. This is the entrance to the Forbidden City, and these are a bunch of Chinese at my house that have visited. And anyway, this is the transplant activity in China. And you can see here in the early 2000s, and then really peaked in 2004, 2005. And that's really when as we saw this dramatic increase in kidney as well as liver transplantation in China, it really brought worldwide attention as to what was going on. And in the summer of 2006, this is a picture of a very frazzled Huang, the Vice Minister of Health, who at the WHO conference in the summer of 2006 for the first time admitted that almost all of the donors in China were from executed prisoners. And at that time he resolved to start making changes, and the first, the current state of transplantation in China at that time, or 95% or more of the donors were executed prisoners. Transplant tourism was rampant, at least 50 or 60%. Once again, you really never knew the exact numbers because they had no registry, they had no regulations. It totally grew up in an unregulated environment. There were over 600 hospitals performing transplants, and there were no regulations governing transplant quality or anything else. So at that time, there was a desire by Huang to regulate this activity, and he asked the China Medical Board, which is this symbol here, for a grant, the China Medical Board said you need a U.S. partner and suggested the University of Chicago. This is Peking Union now, and this is Peking Union at its inception. This is Rockefeller here. So Zhaifu Huang is the chief of liver transplantation at Peking Union Medical Center. He's also the Vice Minister of Health at the People's Republic of China. The China Medical Board was founded by Rockefeller also, as we also know that he founded the U of C. And for the first, just a brief history of the China Medical Board, for the first 50 years or so of its activity, its sole philanthropic recipient was PUMC, which had established the first and only Western-style medical education facility in China. And Western faculty came from the United States to start it. Some of those ultimately came to Chicago to start the University of Chicago's medical school. And you can still see, so this is the kind of the entranceway to the hospital. And if the picture was better, you could see that all these guys were standing right here, and you could still see in this modern-day picture of Peking Union Medical College where they would be standing. So what's the principles that we decided that we would focus on that are associated with transplantation worldwide are altruism, protecting donor and recipients, protection of the disadvantaged, access to quality programs, and punishment for infractions of the regulations that would be there to protect the ethical principles. So the first thing that was done was to call a meeting in Guangzhou. All the transplant centers, all more than 600 of them, were mandated to attend this conference, and the Minister of Health established the criteria for the evaluations, told all of the centers that they would have to apply to the Ministry of Health in order to be able to continue to perform transplant, and that at least the prisoner and or prisoner's family must sign the consent. This is the meeting of Guangzhou's meeting in November of '06. And so the regulatory focus really boiled down to quality, regulating the transplantable organs, transplant tourism, and a source and rights of the organ donor. So the quality requirements really harkened back to the principles that Franny Moore described with field strength in ethics, surgery, medicine, and ICU. There would be an establishment of a committee for organ transplantation to develop and disseminate standards for clinical practice, and there would be national conferences regarding the transplantation. One specific area in liver transplantation are the regulations are listed here, among others. The key point here is that many of these regulations would be similar to regulations that you would see from UNOS or CMS regarding what they would look to in regards to approving centers, or in that matter, insurance companies, centers of excellence as well, would all have these types of metrics to determine quality in an organ transplant center. So the impact of this is that from over 600 transplant centers, there are now about 160 transplant centers. Almost all of them are now Ministry of Health approved. If they're not Ministry of Health approved, there's still ongoing discussion and evaluation, but all of those are at least approved by the provincial level. Applications have been turned down by the Ministry of Health just because they don't want any more transplant centers in the country, and that they were still reviewing the first round of applications. All the provinces have at least one transplant center. The financial penalty for payment of organs was 8 to 10 times the illegal income, and the revocation of the license to practice transplant with an earliest reapplication 3 years hence. Transplant tourism. The drivers for transplant tourism were the rapid access to organs, and the cost was much cheaper than in the U.S. However, in July of '07, there was some reports, and there have been subsequent reports as well, that there have been overseas patients into facilities Specifically, Hong Kong, Macau, and Taiwan people were all okay, but others must apply to the Ministry of Health for approval. This was specifically placed in there for liver transplant patients, basically expats who were working in China who would get acute liver failure and would need access to liver transplantation. They put this in. Yeah.
Was there previously a large United States population going to
Yes.
China?
Yes. Both for liver and kidney.
Do you have an idea?
No numbers, because they were never tracked on this side and certainly never tracked on that side. So there's never any way to really get that number. From these regulations, it certainly has decreased the number of deceased donors that are available. There are other aspects that have impacted the deceased donor pool, deceased donor being a euphemism for the executed prisoners, including Supreme Court review of all capital punishment. Prior to that, the punishment didn't have to be reviewed at anything other than at the provincial level. And so with National Supreme Court review, it decreased the numbers of potential donors. The consents, etc., decreased the number of deceased donors available. And so the number of living donors has dramatically increased over the past couple of years as well. And so recently, a March 17th, 2010 article in the China Daily, organ trafficking to go on trial. And this describes a series of living donors who, a former living donor is suing the ring because he didn't get paid. And the suspects organized 4 livers and kidney donation. This is all what do they call accused of? It's kind of like the Goldman Sachs thing. These are people accused of doing this. And so the trial, which, as it said, may begin in April, was one of the first on organ trafficking. If convicted, the suspects will face 5 years in prison. Approximately 10,000 organ transplants were performed last year, with more than 3,000 from living donors. So now a third of the transplants are being performed by living donors in China, which is almost 6 times that in 2008. And Jai Fu said that he felt that there was a considerable number of them were done with fake identities from hired donors. So they are definitely recognizing this. In previous committee meetings that I was part of, Jai Fu Huang specifically stated that the government was not encouraging living donation. This is part of the reason, but in general, he felt that the legal, medical, social aspects of China were just not sufficient to support living donors. And so, although they weren't endorsing it, they knew that they had to regulate it because of this very issue. But as we all know, it's very, very hard to regulate living donors in this country. And you can imagine how difficult it is in China. So the natural evolution of this is to look towards other sources of donors. And obviously brain death is one of the criteria that we utilize in order to get donors in the United States. And there's been some effort of that in China. Specifically, Professor Chen has really taken the lead in a lot of this area in China and has overseen 70 such cases of living donors. So even though they don't have a brain death law, he's been able to discuss it with the families of patients who are brain dead, and they have allowed him to proceed with brain death. So once again, they recognize that brain death is going to be necessary to ultimately fulfill their demand. Right now, there's still no brain death law. I've been involved in a number of conferences to establish that, and from a medical point of view, they understand it, they recognize it, but it's really the interplay between the Ministry of Health and the Ministry of Justice in terms of trying to get a law passed, and we'll get a little bit into that. So one of the meetings that I was at, which was organized by the Ministry of Health, but not chaired or actually attended by the vice minister, because he didn't want to make it look like transplant was actually driving the whole brain death discussion. And so it was it's an important aspect in the medical care overall in China, where 20% of the ICU beds are currently taken up by patients who are brain dead, which ultimately doesn't really, from the US dollar standpoint, but from a China standpoint, that means a lot, $360 US per day. The total cost is billions of dollars of billions of RMB, and as the reevaluation goes, it could be billions of US dollars as well. About 2% of the country's medical resources are taken up by brain dead people in the ICU.
So
Lainey?
they never withdraw?
Right, right.
Okay, so it's just, we can just see how long we can keep.
Yeah, right. So that's actually one of the areas that we're trying to get into. So any brain death policy must benefit the entire healthcare system and not just an issue regarding transplantation.
So there's no DNR either, they have just CPR people?
Well, I mean, I think you can get DNR orders. Yeah.
We just go back to living donors. So do they
Yeah.
allow people with Hep B and Hep C to donate, or
Well, if assuming that they don't,
they match the recipient?
well, I mean, you're certainly not cirrhotics, but probably Hep B core antibody positive would be okay. Probably not hepatitis surface antigen positive. So this is just a review. There are, I mean, as usual, Americans are so focused on the U.S., we don't realize that there actually are a number of different other alternative definitions of brain death, and these have been reviewed at brain death meetings in China, and recognizing that now it's almost 100 countries have brain death regulations. So cardiac death only. Brain death can one of the focus concepts was that brain death can promote life. With CPR, in the face of known brain death, stimulates early cessation of CPR, whereas if there was a brain death, one could continue until there's no hope of brain activity. It would also help the legal system. If someone is shot in the head and is clearly dead, brain dead, but his heart continues, then whoever shot him in the head cannot be prosecuted for murder, because that's not what killed him. He ultimately died, say, 3 months later of some sepsis, and so the issue of who is actually legally responsible for that person's death becomes a question in China. So those are all issues that are dealt with. So the current proposed definition of brain death in China is irreversible loss of all brain function, including brainstem. The clinical cause of coma is known and is reversible with laboratory parameters. They were mentioning this N13-9, which I didn't know what that was, but there were discussion of that as well, and that there would have to be at least an observation time of 12 hours.
Are they going to use the same standard for kids and adults?
Yes. There was a breakout into small group sessions, with really each of the sessions coming back with general agreement regarding the need for brain death and the criteria for brain death. There was also concern over legal liability, just as there was in the States when the initiation of brain death. And they were also concerned about whether each of the hospitals would have the appropriate diagnostic equipment in order to make the diagnosis of brain death, etc. So a lot of issues that we have to think about in terms of driving this from a concept of brain death to a practice of brain death, not only in Shanghai and Beijing, but in all the little rural areas as well. So in Hong Kong, there is a brain death concept and laws, and that it's within the province of the physician to make that, whereas organ donation and allocation is regulated by the government. So there's a line, just as there is in the U.S., a line between the diagnosis and the criteria of brain death and what happens afterwards. So the likely next steps, ultimately, the Ministry of Health may have to stop, quote, working with the Ministry of Justice and basically just announce some brain death regulations, if it can make that happen politically, which right to this date has not happened. The Red Cross will initiate PR regarding brain death and the need for organs. There'll be regional organ procurement organizations will be developed, and the regional allocation systems will need to be identified as well. Let's look at the impact of potential brain death in China. There are at least 350,000 motor vehicle accidents a year in China, of which 150,000 of them are brain dead. And so the impact of this over time, if you looked at implementing this in nationwide and getting improvement each year in the number of organs and donors you could identify, you see that there's a pretty significant increase up to about 35,000 donors. That's not the organs. If you can multiply that by 3 or 4 to get the number of organs, versus the number of organ donors in the current system, i.e. executed prisoners, less than 5,000. And it's really been my goal from my outset of working with China is not necessarily to condemn them, at least publicly, about using executed prisoners as a donor source, but really to develop a whole different organ donor system that would make this system useless and superfluous. And hopefully this is one of the areas that we're going to make some progress over.
They have safety belt laws?
Yes.
Yes, and they're not enforced.
Yes, that's right. But you do see the signs. You must wear your safety belts, but nobody enforces them. Helmet laws. No helmet laws. No helmet laws. Yeah. Yeah, it's a lot of pedestrians just getting hit. Although, I mean, I don't know, Renslow has been traveling in China as well as long as I have, for probably longer. And every time I'm on a freeway, it's not infrequent that I see a traffic accident that more than likely had a fatality involved with it. Right, Renslow? Yeah. I mean, I'd much rather over there travel on train than any distance than a car, because it's pretty scary. So Chinese organ procurement organizations have started to be developed, and starting in 2001 by the Chinese Transplant Society to establish organ recovery from brain dead donors. And this was really work by that Dr. Chen that I showed earlier. And hospitals that participated in these programs are qualified to share all of the donors from these donor hospitals, and the donor families did not receive any financial benefit for their organ donation. And here's, you see some of the progress that has been made in this. Not huge, but at least the concepts are there, and these are the number of organs that have been used. This is a picture of a brain-dead donor who was being seen before the transfer to the operating room, and even before the organ procurement, a prayer for them in the operating room. This is Dr. Chen, who spent a lot of time at Cambridge and really learned deceased donor transplantation there, and is trying to bring that to China. This is some of the other people. You can't really see that. They are starting to have transplant games just like the U.S. does, and this is I think a heart transplant. There's a lot of focus from these deceased donors on heart transplantation, because obviously that's one of the areas with their current system of executed prisoners that's really not, that are underserved, let's put it that way. And with brain dead donation, you're able to do that. So they are.
Prisoners differently, right?
What's that?
You know, they kill the prisoners differently, right?
They shoot them in the head.
Oh, I see.
Yeah, they shoot. Basically, all their current donors are shot in the head. Wait until the heart stops, and then are declared. They're a DCD in the U.S. vernacular, donation after cardiac death. It's just that the inciting events were a shot in the head, brain death, loss of blood, heart stop, declared dead, then given to the organ procurement team.
Really, they're not given first? They don't go to the OR first?
No.
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 Okay, so that's why you don't get the heart.
Right, right.
In the OR. Hopefully.
So this is a heart transplant recipient, and here is his donor, a 25-year-old female, a car accident, death, what a surprise. This 56-year-old recipient with a long history of cardiac problems. They have public service announcements now showing that new life brings a new journey, and these are amazingly enough pictures of actually organ donors, like things that we wouldn't actually come close to in the U.S. Yeah. As I said, there's medical acceptance, the diagnostic criteria, but there are legal, political, and social concerns. And really, as of today, there's very little progress towards actually implementing a brain death system.
Is the resistance a religious thing? Or what?
There's some concern that there would be religious or social resistance. But right now, as far as even at the top level, the discussions between the Ministry of Justice and the Ministry of Health aren't going anywhere. So we've decided that we're going to try to find a way around that system. And if you look at the whole group of deaths in the hospital, or that would be this big group. And what we're going to try to establish is an in-hospital DCD program, which would be all of these, with a portion, the blue circle, being the patients who might also be brain dead. So if you think of all patients who might die in the hospital, at least in China, a fraction of those patients are going to also be brain dead. So we're going to try to concentrate on this whole group with the recognition that some of these would be brain dead. And so we've established protocols for a DCD program. In China, the ones obviously that would also be brain dead, we presume would die more quickly and be better donors. We have requested, we are writing a grant right now we'll submit it to the China Medical Board for $1 million. And if the China Medical Board approves that grant, then the government has also approved $1.2 million for this essentially development of a DCD program in China that would, I think, really change the course of transplantation in China, as well as the world, in the sense that China has really led the whole Asian region in recognizing that transplant tourism is not something that should be encouraged. Other Asian countries, following the work that we've done in China, have passed laws to curtail transplant tourism, and I think if we can get essentially a DCD program going in China, once you are able to show that you can get more organs from that type of system than the executed prisoners, then the avalanche will clearly, just as it was with living donors, go that way and make it a much more successful system. So in summary, transplantation worldwide is bound together by a collective ethic regarding the right, safety, and the respect for the donor. The recipient is really a local or national issue, and China is on a course that will make it the most active transplant country in the world, probably in a relatively short period of time. But the important aspect from our point of view and an ethical point of view is that it's pushing forward in a way that is consistent with international standards and respect for the donor and the recipient. So once again, I thank you very much for allowing me to speak. With a few minutes for questions. Lainey?
So you showed an incredible number that your projections would have about 25,000 deceased donors by, I don't know, another decade or so. Give us an idea of what number of individuals need a liver transplant, given how high Hep B and Hep C.
Yeah, there's
it's just a drop in the bucket.
Well, it's estimated. Once again, we don't. I mean, there's not a national list, so these are estimates. But it's estimated that if you had the economic ability to pay for, and and you had essentially the same criteria that you have in the U.S., that there would be 1.5 million people in need of a liver transplant alone.
Right, so 20,000.
But the issue is that economically, currently China is not able to afford that. Even the 20,000. So, you have to project this, and that's per year. 1.5 is, the number of people who currently need it. As long as you're starting to chip away at it, then you're at least making progress. I mean, you could say the same for the U.S., right? We have 17,000 or so on the liver transplant waiting list in the U.S. We're doing about 6,000 transplants a year. The waiting list is still growing, but at least it's not growing, that extra 6,000 that we're at least able to transplant. So similarly in China, if there's 1.5 million, at least as long as you're able to transplant 20 or 30,000 of those a year, then you're helping.
I got two comments. The first is, no matter how many times you say they're not connected, what you've said at least shows me that organ donation and brain death legislation are intimately and essentially connected. They're just not working yet. The second thing is, it worries me that you can say to someone, I'm going to shoot you in the head in a week, but right now I want you to sign this absolutely voluntary consent. I mean, that's baloney.
Right.
We've decided 35 years ago that we couldn't ask people in total institutions.
And that's being rediscussed as well in the States. There's a UNOS conference now, or committee, that's addressing consent of prisoners in terms of organ donation. Right, Lainey? Did you see that?
Well, actually, so the ethics committee said that we're not going to allow prisoners to be non-directed donors.
But there's...
That was our meeting last week.
Oh, okay. So that's new stuff. Because they're what I...
Because it's unethical.
Right.
Because it's impossible.
Well, it's actually, so there's also practical issues of just, so getting prisoners into hospital rooms requires guards and all this, so it's actually a much more expensive non-directed donor than a regular person. It's not clear whether they would be doing it out of this altruism or just escape the prison for 2 weeks.
Well, it kind of reminds me about the old days when they used to give money to the hangman. They'd walk up to the noose and they'd give money to the hangman because that would mean a better hanging or a better knock with the axe. I mean, you're going to shoot me in the head a week from now. Now, if I give you my organs, do I get just one shot, whereas it might be kind of
But it's also been proposed as a prisoner's rights issue, too, that they have the right to donate their...
We're very clear that they have the right to donate organs after they die. We're very clear that they have a right to donate as living donors in an emotionally related circumstance. It was just that we weren't going to extend it to the non-directed altruists.
But that's because of cost?
No, because of vulnerability.
But how are they, we can argue this in a different venue. How are they more vulnerable in a non-directed situation than in a directed situation? But anyway, that's probably...
They're vulnerable in a directed situation.
Yeah. Oh, okay. Well, so you're right. There's that link and ethical problems with the executed prisoners. There's no doubt about that, and I don't defend that. I don't support that. But as I said, my goal has been to develop a different system so that system goes away. And in fact, Jaifu has stated in public meetings in China that ultimately the Chinese government wants to eliminate the death penalty. So. But we also recognize that really from a number of different reasons, at least we got to find a different source of organs in order to be able to allow that even to occur in reality.
Is there any kidney from those that they are not being executed, like those who are permanently there, prisoner, or any political prisoner?
There's no evidence of that I've ever seen of the long-term incarcerated prisoner who would be forced to donate. Now, the issue I think comes about as to what is a capital offense in China, right? And there's concern that capital offense might be having political opposition. And if you are an opponent of the government, that might be enough to get you a death penalty. And then if that's your scenario and your sentence is death, then you will be approached potentially to be an organ donor. But I've never seen any evidence of the long-term incarcerated prisoner who's not going to die to be forced to be an organ donor. That doesn't necessarily mean it doesn't exist. I've just never seen that evidence. And even some of the reports earlier in the 2000s have really not gotten legs and felt to be valid. Sandy?
I had a couple of related questions. Putting aside the whole prisoner issue, if you have somebody saying in an ICU who is potentially going to be a deceased donor, do we know anything about the nature of the conversation between, if it's a surgeon, and the patient's family about the use of organs post their
Right now, I suspect that would be a surgeon or a probably not the transplant surgeon. It would be their healthcare provider, whoever that is. But not. I guess what I was trying to differentiate. In the early days of U.S. organ donation, it was similar in the fact that it was the physician, the potential donor's physician, who discussed with the family about organ donation. Whereas in the U.S., we have now moved towards the organ procurement organization personnel doing that because it's felt that the consent rate is better and they're better at it, etc. Whether that is right or not, but that's how we've evolved. And in China, certainly it's not the transplant surgeon that is having that discussion.
And the second part of my question is, if there is no family present, what is the policy that's applied? Is it one that approaches presumed consent?
No.
No.
If there's no family around, they're not going to go. It's too early in the process to go there.
Are prisoners in either U.S. or in China allowed to receive transplants?
Yes. Well, in the U.S. they are. Actually, I don't know in China.
Now, you say the Department of Health and Justice don't see eye to eye on this issue.
Yes.
Is it just political, or is it anything approaching to the ethical issue?
I think it's political. I think it's just political.
It seems to me how you think about donating organs after death kind of depends on the culture.
Sure.
I mean, here you want the individual to consent because we have this idea that the individual, owns their organs after they die.
Mm-hmm.
But you don't, and I don't really know how it is in China, but if they didn't see ownership of bodies in the same way, then...
They do.
Okay.
Yeah. I when I first started going over there, I had that same thought at some point, is that could essentially a government, a socialist government, communist government as we would think of it, could they kind of mandate that the dead body is a ward of the state, and therefore the state could do whatever they wanted to with it. Whether they could do it or not, socially and culturally, they cannot do it.
Well, could the government sort of mandate that, or separately, if people have the feeling like, my body's just mine when I'm using it?
Yeah,
words,
they don't. They don't.
That.
The cultural issues really. There's a lot of Buddhism thought of. And when I first started going over there, people would even tell me that living donors would never be very well accepted in China because everybody wanted to be buried whole, and if they gave an organ away, they wouldn't be whole. Whereas, and one of the things that I have learned is that transplantation, when it's provided, there's no way to go back, and so you will always try to figure out how to find that third party to provide the organ, the substrate, to get the transplant done, whether that's through a living donation, and voila, I think people accept it once the cadaveric is not available because of the regulations. But in terms of globally, whether you could just say that we're going to do what we want to with it, that would not go over.
Well, certainly with the cultural issue, always that you must preserve or respect your body because it is an inheritance from your parents. And filial duty is a very important aspect of being a good person. So if you practice filial piety, you would not donate anything within your body. And that's one of the reasons why a lot of the men did not cut their hair, because even snipping the hair off is a violation of your biological inheritance from your parents. So the cultural issues will be certainly against.
Yeah, right. Mark? And welcome back from the ISHLT.
Follow-up to Linda's point. What do you think of the long-term prospects of living organ donation, let's say within families in China?
You just came. I showed some data about that. There's actually about a third of the transplants in China are now living donors. And there's a trial that is supposed to start in April about a ring who organized living donors for pay, and one of the donors is suing the organizers because he didn't get paid and all that. So there's and Jai Fu has come out in strongly opposition to that and said that we have to address these issues, that a third of the living donors or a third of the transplants are from living donors, and a good proportion of those from these types of rings. So as I said, once transplantation is established and you try to, it's like a balloon. You squeeze here, it pops out somewhere else, and you squeeze down donation from executed prisoners, and living donation has popped up. We got to now squeeze down on living donation, and hopefully cadaveric will push out.
I'm really concerned that 20,000 makes up about 2% of their need, whereas our 6,000 makes up about 25 to 30% of our need. Now, we could argue whether our need actually is an underinflated number because we don't want to put people on the list. But when it's such a small number, 20,000 to 1.5 million needed, is this going to be something that like the Ministry of Health will decide they're not paying for, and it'll be a cash only? Not buying the organs, but for buying the services. How are they going to?
For transplant?
Yeah, if they get it up.
That's essentially what it is now. It's pay. There's the government doesn't.
Purely for pay.
Yeah.
It's only the 20,000 reported.
Yeah. So there's Shanghai and maybe Beijing have had discussions about their local governments paying for kidney transplants because the costs are much smaller, right? But none of them are even close to considering government pay or as a source for liver transplantation. That's not been discussed anywhere. So it's a.
So is that a social issue about wanting to be a donor if you know that your family could never afford it?
I haven't heard that as a problem.
I've heard about the Israeli government's use of priority status as a way of encouraging voluntary organ donation, organ donor status, at least on licenses. Is that, and I'm curious about how priority is to be used in countries like China, or how it might be used in order to increase the number of living donors.
And when you say priority, what are you talking about on the list, on the recipient list, or?
What I understand is that, and you would know this better than me, that in Israel, if you sign your driver's license and state that you would be willing to be an organ donor, then if you should ever need an organ, you would have priority over other recipients as a way
Right. Yeah, yeah.
It's just something that would be, I don't know, did it actually pass, or is it only just being discussed? I mean, it's a very recent event.
I don't know. I thought that it was passed and that this was
Because I
law.
thought one of the reasons that there was complaints about it is because the Orthodox groups will not donate it, so they were then being discriminated against. And
Right. Exactly right. So Israel has a big problem with organ donation. It's very poor organ donation, and they're actually one of the as a country, one of the biggest buyers. Yeah, I was going to say transplant tourism, may a little less politically charged, but buyer is the correct term.
But they also, I mean, there was the ring in New Jersey.
Yes, the ring in New Jersey, and
the trailers were coming as
yeah.
vendors.
And I've heard that there's some places in Colombia that are more like Tel Aviv than Colombia.
How can priority be used as an incentive for drawing on voluntary organ donations? Is that something you'd admit in the system?
In the U.S., at least, that's generally been frowned upon. That organ donation should be really felt to be an altruistic concept, not a one for some type of benefit.
Don't you get some years if you donate a
You get 4 points.
You get 4 points.
4 points. So that's a
That's a lot.
okay. So that's a big priority.
But that's only if you were former
Yes.
Not if you said I would like to be a donor. You got to really go through it, go through the whole process.
Given the dramatic shortage and the fact that people have to pay for their transplants, do people get retransplanted?
I've never asked that question, but I bet not. Well, yeah, could be.
The Americans or any transplant tourists that have gone to China when they get these transplants that they, I guess, buy, who treats them after?
So
They come back to us and they
yeah, they come back to us. In fact, Mark and I, a long time ago, I came up to his office and said, Mark, this transplant tourism stuff is growing. What should we do about it? Well, we figured out we couldn't do anything about it, but more to the point is what was going to be our policy at this center in regards to treating patients who had gone over and received organs. And our policy, our discussion, as well as what we've decided in the transplant center is that we would treat those patients, whereas other transplant centers have said no, that they will not treat those patients.
Can anything be done about all the hepatitis?
Yeah, so they now have a universal hepatitis B vaccine program. Yes, so things are being done in more, universal sense of trying to decrease the incidence of hepatitis B. But, yeah, it'll make a difference. You can see actually differences in prevalence rates in the young versus the, even teenagers. So it's definitely made a difference. Whereas overall, the prevalence of hepatitis B is around 8% now. Just even a couple of years ago, it was 10%. So it's making a difference. And if you look at the younger cohort, and it's not just a time aspect, the younger cohort's incidence and prevalence of hepatitis B is way down versus the older groups. Mindy?
Your slide about the lack of passion regarding taking care of disease process that result in organ failure, what do you project will be the impact of obesity, the fatty liver and meat transplantation in the United States?
Well, that's as hopefully hepatitis C and B go down, it's very much projected that NASH, fatty liver disease, is going to be the one that takes up that demand. So, yeah. So all the people who eat brownies. Yeah.
Do you say that in Colombia the government is in favor of tourism for transplant, and do they get any money?
The government, as far as I know, doesn't get the money.
Like taxes
But
or anything?
not, only in whatever a tourist would spend while they're there. But they. I don't know if the government encourages it, but they don't. No, and I don't know if the government encourages, but they allow it to happen currently. Whereas many governments have taken the proactive step of banning it, and as of now, Colombia has not banned it, and it's a big site for transplant tourism right now.
Do you know the reason for it? Is it had to do with the cartel or something?
Oh, I don't know enough about the details of Colombia's transplant tourism market. I mean, Mark, maybe you do. Do you know anything about it?
And if I did, I couldn't say.
Okay. Anything else? Oh, there's something in the back.
What was the price of the organs that people were paying before this regulation changed?
Here. It varied. A common number that I'd heard was 30,000, but the once again there was a relationship between the justice system and the organ donor system that helped incentivize that aspect. It was, and probably still is, fairly common practice of the person who committed, or the family of the person who committed the crime had to compensate the aggrieved party some amount of money. And so the donor, the prisoner who was in the prisoner who was about ready to be executed and could get $30,000 for their organ to be able to pay off the fine that the Justice Department had put on to him or his family, in addition to the penalty of death, would accept that and say, sure, I'll let you have my kidney or my liver, but the $30,000 goes to the aggrieved party to pay off the debt for my family. Yeah. Interesting stuff, huh? Thank you.